yourself. You want to do it?
You can, yeah, that's fine. You can introduce me, that's fine. I'm just going to make an announcement that we'll start in like 5 minutes so people have a chance to log in.
Okay, sounds good.
Okay. Okay, for all those that are online, we're going to go ahead and start in about 5 minutes just to make sure that we give everybody a chance to log on. So we'll start in 5 minutes.
And at some point, is that supposed to be pointed elsewhere?
They're just using it for the mic.
Okay.
I can't remember his name. Who's that? Sharon, I'll ask Sharon.
Go ahead and begin.
Okay, so I'm Nick Nystrom at PSC. I'm Senior Director of Research, and it's my pleasure to introduce Dr. Shawn Brown. I've enjoyed working with Shawn for, I don't even know, was it 15 years now?
About that, yeah.
Something like that. Shawn's training was as a quantum chemist, as was my own, so we share that. And then we've both gone off into other things. Shawn has moved into public health. He's been working in that for quite a few years. He did a stint at the University of Pittsburgh Graduate School of Public Health. And now he is back at PSC, leading group here, doing a number of projects he'll be talking about today. So, turn it over to you.
Okay, thanks, Nick. As Nick said, my name's Shawn. I'm the Director of Public Health Applications here at the Pittsburgh Supercomputing Center, and I lead a group of individuals that work on simulation, modeling, and data analytics for public health applications. And I'm going to give you an overview of many of the projects that we're doing in our group. And then after that, we have two other talks that will be more project-based. One will be by our public health manager, Leila Haidari, and then the other one will be by DePasse for my group. So what is the importance of computational modeling in public health? Well, public health is a very cross-cutting discipline. It involves a lot of things like logistics, epidemiology, ecology, system science, economics, data analytics, and social science. And all of these combine to form the idea that we want to improve the health of the public through a number of means. And so we focus on using computational modeling and data analytics because we think this is essential to make sense of the complexity of public health and to understand all of the important factors that are needed in order to improve the overall population's health and well-being. So in 2011, 1 month of 2011 and then into 2012, I came back to the PSC to form this group called Public Health Applications. And what our group is about is we have a number of folks in the group that are both developers, epidemiologists. Very few of them actually have a public health background, but they are very talented and very smart people, and we apply their know-how and knowledge as well as people from the PSC in general to solve public health problems. We also incorporate technology. Being positioned at the Pittsburgh Supercomputing Center gives us access to a number of unique and interesting technologies that enhance our work, including the Bridges supercomputing architecture, the Data Supercell, and our own supercomputer that we host for the NIH, which is named Olympus. So being at the PSC gives us access to the latest and greatest state-of-the-art supercomputing technology to enhance our work and take our public health models beyond where they could be if we were just on our own at a university. And then we also have several partnerships that we leverage. We work with a lot of different people. Public health is a very collaborative field where there are both universities. One of our big collaborators, Johns Hopkins University. You'll see that here in many of the projects. We also collaborate with organizations like UNICEF and WHO, which are international authorities on health and well-being, as well as foundations and NGOs and other universities. So we have a wide array of partnerships. We get funding from a number of different sources, such as the Bill and Melinda Gates Foundation, the National Institutes of Health, and also from UNICEF as well. So the first application I want to talk about is agent-based modeling. So agent-based modeling, what you're seeing here is a visualization of the state of Pennsylvania. And you're seeing as on the state, we see blue and red showing up over top of the state. From blue to red, what you're seeing is the spread of an influenza pandemic in the state of Pennsylvania. As it gets more red, more people are getting sick during that time. And this is one season. I just let it repeat because I'm long-winded. But what this is representing is our agent-based models, where we actually build a computational society in the computer, and then we use that to drop a disease in and look at how can we mitigate, how can we improve our response, our government's response, our individual response, and our public health sector's response to an emerging pandemic. So the basic structure of these agent-based models is, for influenza, is we have a number of different places that we consider where influenza can actually spread, such as the workplace and schools. Schools are a big driver because kids are snotty and don't wash their hands. The household, so every person has a household. And then we also represent the community. And what we do is we actually have a synthetic population that we put into the model that identifies a realistic, statistically realistic population of the area that we're looking at, and we actually assign individual people to households, and they move about their day, and we then infect one of them, and the kids will go to school, adults will go to workplaces, they may have a chance to transmit the influenza, and then these people might go out to the community and transmit influenza again, and so on and so forth. And that's how the agent-based model is able to represent an emerging epidemic. We use agent-based modeling because it's very explicit, both in a spatial and temporal sense, which is very important in looking at the spread of infectious diseases. So we have populations, as I was saying, these synthetic populations. So for instance, one thing I want to stress, one of the reasons we're at the Supercomputing Center is that these are very computationally intensive models. They require lots of memory and lots of computation, which makes platforms like Bridges and Olympus very useful for these models because we have a large memory capability. So for instance, something like Allegheny County, if we wanted to do a population there, that includes about 1.2 million people, that takes about 1 gigabyte of RAM to run. If we want to look at the DC metro area, which is going to be the focal point of a talk that Jay is going to give here in a little bit, that takes about 7 gigabytes of RAM to run. Pennsylvania actually takes about 20 gigabytes of RAM. That has about 12 million people. And then if we want to go to the entire United States, which is about 300 million people, we need very large memory capability, something on the order of hundreds of gigabytes of RAM just to run one realization. Now these are stochastic models, meaning that they're random, so we start with the same initial conditions, but random chance actually dictates how the disease spreads through the population. So each time someone comes in contact with another person, there's a random rule to say, based on a number of different conditions, will they transmit influenza? And so the simulation doesn't produce the same results every time, which is like reality, because a population is a highly random and chaotic system. And so we have to do a number of different runs, probably on the order of 10 to 20, just to be able to sample the statistics of our model. And so we basically have a bunch of independent runs. We ship those off to a cluster, running each simulation in parallel. And then we write a lot of tools. That's one of our focuses, is building infrastructure and tools to be able to gather this data and be able to serve it up to the public, to decision makers, in a way that's not numbers in a table. It's graphs and visualizations, and that allows us then to inform decision makers about what our possible strategies might be in order to mitigate influenza. So one example study that we published in BMC Public Health is a study that looked at school closure. So I was heavily involved in 2009 in the H1N1 pandemic response in the US government, even so far as being embedded in the government doing modeling for decision making. And one of the questions that came up early in the pandemic was, should we close schools? It seems like a natural thing, since schools are a very big driver of influenza spread, as I said, because kids are snotty and they don't wash their hands. And so it's a natural idea to go ahead and close schools, but the community was getting a lot of mixed messages about whether they should do this or not. And it was especially important in 2009 because the vaccine, nobody really knew at the beginning of the epidemic how bad it was going to be. And on top of that, the vaccine was really late to arrive in the United States, even after the peak of the influenza pandemic in the United States, and that meant that the vaccines may not have been effective. So this was actually something that was a hot topic at the time. And so we took our Pennsylvania agent-based model, where we had a representation of every adult and child in Pennsylvania. We had a representation of every school in Pennsylvania, and the kids went to school based on their assignments, where they live, and the age makeup of the school districts, and that created a realistic canvas for which we could test policy. So what we did was we did a number of different school closure policies, varying the length of, for instance, the length of time that you would close schools. And as you might guess, closing schools for longer and longer periods of time create a lot of hardship on parents and the society, because it's costly. And I'll show you in a second our cost analysis of that. And then also we did things like we looked at the trigger to closing schools, like how many kids would have to be detected to having influenza in school. So we did a very wide sensitivity sweep. What I'm showing you here is one of the sensitivity sweeps for an influenza pandemic of R0 equals 1.7. On the y-axis, you're seeing what we call the incidence. That's the number of new cases in the population per day. So if someone gets infected, that's one more on the incidence. On the x-axis is the number of days of the pandemic. So as you can see, this blue curve here is the baseline. That's with no school closure. That's just drop influenza into the population and let it spread. You see at day 0, we're starting to see a rise in the number of new cases till we get to a peak, and then it curves back down and goes to extinction, because eventually you're burning out the number of susceptibles in the population, and therefore this is a very normal pattern for influenza, which we call an epidemic curve.
What's R0?
R0 is a normal parameter in it is a common parameter in epidemiology that refers to the number of naive people that you can infect if you're infected. So if I'm the index case per se, one person infected, it's on average the number of people that I will infect, assuming that no one else is infected. It's a sort of a common measure of the strength of an infectious disease. Flu generally ranges between 1 and 2 of R0. Measles is something like 13, 12 to 15, somewhere in that range, which is why it's very highly infectious. So the other curves here are showing where I'm implementing a school closure policy of increasing weeks from 1 week to 8 weeks. And you can see a very distinct characteristic that even going out to 8 weeks, we still see a rise. Once the schools reopen in the population, we still see a rise up of the pandemic. And so this means that while we may be changing the nature of the pandemic, we're not necessarily saving a lot of cases. We're not preventing a lot of cases of influenza. And so this number here on this table is called the attack rate. That would be the percentage of people that get infected in the population. As you can see from no closure, we're getting about 38% infected. 1 week doesn't really fix that. And then we have to go somewhere around 6 to 8 weeks of school closure to actually have a significant reduction in the attack rate of the pandemic. Now, why is that important? Well, so one of the things we did here is we added a cost model to this, an economic analysis model that took into account things like how much would school closure cost. So we incorporated items like the parents, the number of parents, single parents or whatnot that would have a hardship of having to stay home. So we proxied them by productivity loss that they would miss work, and that would be added to the cost of the school closure, as well as the productivity loss from the education professionals. And then we have a factor that's the cost of the disease, and that is when people get sick, they miss work, they may die, and we have it. So this is a sort of an economic cost of from a societal perspective of the cost of disease. And so if you're mitigating the disease, you would expect that to go down because you'd have less cases. And then the play is if the intervention is not as costly as the disease burden, so what you save in the disease burden, if the intervention doesn't cost that much, you'll get cost savings. If it's cost more, you'll get a net cost. And what we see here in this chart, a number of different scenarios. The red bar here is the cost of disease. And you can barely see that it's moving. It is moving down in most of these cases because we are saving some cases, some influenza cases. But the green bar is actually representing the cost of school closure and starts getting very significant at 8 weeks. And remember I said that we had to go to 8 weeks in order to get a significant decrease in the attack rate. And so if we look at the net cost of school closure, in almost every case it is a net cost, in some cases very significant. It ends up being that it has about an 8-week school closure has about $1,000 per case, cost per case averted, which is compared to influenza something like, vaccines are about $100 per case averted. So school closure from an economic standpoint, from a societal perspective, is very costly. Now, does that mean one of the dangers of doing this kind of modeling is that means don't do it? No, that doesn't necessarily mean that. It's just another thing for you to consider if you're making a decision. Because, for instance, if a kid dies of influenza in my daughter's school, she's not going to school. But it's to give the decision makers an idea that this is going to be something that is going to be a hardship on your population. So you should consider that when you're deciding whether you want to close schools or not. Another paper in influenza that we published in a journal called Health Affairs, which is a very well-read journal by policymakers, is a study on ensuring the benefit of equal and timely access to influenza vaccines. So we took our Washington, D.C. model and we divided up the counties by socioeconomic status, and we looked at different scenarios that involved vaccinating the poorer populations versus vaccinating the higher income populations, and looking at what would the impact be of making sure that everyone had equitable access, or if there were imbalances in the equity of access. So what happens is, this is just a table of results that shows that if we, at varying different rates of vaccination, in every case, if we vaccinate the lowest income counties first, we're seeing a greater impact. We're seeing more cases averted, we're seeing a better economic outcome, and that we're losing, we're getting less productivity loss and such, or we're saving more productivity loss, excuse me. And that's good. That's what we're looking for. So it doesn't make sense in a lot of cases in influenza vaccination strategies. It's the higher income, more affluent districts that have better access to these, or may have more uptake or more coverage. And so what we wanted to look at was, what is the impact of not ensuring that your lowest income districts actually get vaccinated in a timely manner. This is just a pictorial representation of this, that the impact of delaying this. So, like for instance, if you have an equity imbalance in that the higher income counties get the vaccine first and lower income counties get vaccines at a delay, you're seeing that this is with no delay, so everybody gets the vaccine at the same time. And each of these subsequent epi curves, which is the same sort of epi curve I showed you earlier, you're seeing a much bigger increase in the pandemic, and that's not just in the lower income districts. That is in everywhere. So one thing is that you're not helping yourself if you only if you have an imbalance of access. You really want to target the populations that need it sooner. That's not necessarily an intuitive result, but nonetheless the model bears that out. So another project I want to talk to you about is one that we call RHEA, which stands for Regional Healthcare Ecosystem Analyzer. And this is a software platform that is an agent-based model, again, of a healthcare ecosystem. So it includes all the facilities like hospitals, nursing homes, long-term acute care facilities, and the like that are involved in a healthcare ecosystem, like, so for instance, like UPMC or Orange County, which is where we've done a lot of our modeling because of we partner with UC Irvine on this project. And this platform provides a virtual laboratory for us to explore things like hospital-acquired infection spread, like MRSA and C. diff and CRE, or also looking at hospital operations and how can we improve care to people throughout these healthcare ecosystems. So in this model, each agent is a virtual patient, so they enter into the system. Each patient is represented individually by a computational agent. They move between the community and the healthcare facilities. Turns out that in healthcare ecosystems, one of the big drivers is transfer. So people go between facilities for various and sundry reasons, from nursing homes back to hospitals, or hospitals to acute care facilities. And so we're representing that flow of patients in the healthcare ecosystem, and that has a big consequence on the spread of disease through the ecosystem, in that if you're not detecting cases in your own facility, those people may be transferred out and start spreading disease in other facilities. And our patients can have any number of different characteristics, including age, ethnicity, comorbidities, disease status, and we can really provide a rich environment to explore how hospitals and healthcare ecosystems can improve their care and prevent disease spread throughout their facilities. This is a graphical depiction of the model. So we have, for instance, a hospital in the system. Hospitals are made up of wards, and each of the wards have a number of different beds in them. So we get data from hospital systems about how many beds are in each ward and each facility. And then we basically move the agents through those. And then within the facilities, within these wards, if you have an infected agent, they can then transmit disease via a normal SEIR model or differential equation model-esque mathematics. But it is an agent-based model in that every agent moves individually through the facilities and makes their own decisions throughout the day. So one of the studies, one of the first studies that we did with this model is just modeling the spread of MRSA. We've done a lot of work in MRSA, and one of our colleagues, Susan Huang at the UC Irvine, is one of the world's experts. There's very few people in the world that know more about MRSA than Susan does, and so we're very lucky to have her as part of this project. And so what we did was we looked at just the spread, and if I have an outbreak in one hospital, how does that affect other hospitals? So you might think in the healthcare ecosystem, well, that's their problem. They've got MRSA spreading all over the place in their hospital. That's not going to affect us. But that's not really the reality. So we used our RHEA model of the Orange County healthcare system to show that if we started an outbreak, say, in Hospital 18, and I can't tell you which hospital that is because of the data restrictions, but there are lots of hospitals in the system, you will actually see that there will be a rise in the cases of the prevalence, which is the number of cases on a given day at the facility over years in other hospital systems. And so this is not, a me-only kind of approach. If you're and our healthcare ecosystems are very connected now. Even if you're not a part of a big network like UPMC, you're still connected and transferring patients and getting patients in from all sorts of places. So then we also went to look at the importance of nursing homes in the spread of methicillin. So we have a paper in Medical Care about this. And then we also wanted to show how hospitals can coordinate. So another paper in Health Affairs where we did some simulations of how hospitals can coordinate and on infection control and obtain better results rather than just one hospital acting alone. This graph I'm showing you here shows that if we have one hospital doing, or all the hospitals doing the intervention, you'll get this number of cases averted in the population. But even if we have, like, say, the highest capacity hospitals, and on the x-axis I'm actually increasing the number of hospitals that I'm adding to the intervention strategy, we can still see a very large effect just by intervening in a few hospitals. So it's all coordinated. It's not just an all or nothing thing. One hospital, whatever one hospital does, another hospital feels in one of these healthcare ecosystems. We've also looked at one of the key areas that we've looked at is contact precautions. Again, Susan Huang is an expert in this topic, and so we've looked at the intervention of using contact precautions, which is essentially isolating a patient in a room and making everyone that comes in and out wear masks and gloves. Very common technique in hospitals. And looking at the potential impact of using just that to control MRSA spread. We've also looked at other diseases, including VRE, and we also have looked at things like CRE and C. diff as well. This is the team, the RHEA team. It consists of our coordinator, Sarah Barsh, who is at the Johns Hopkins University, who's a longtime collaborator, been with the team for quite a long time. We have a number of clinical experts. As I said, Susan Huang is one of the world's leading experts in MRSA, as well as Lauren and Jamie McKinnell are also clinicians that are a part of this project. And Dr. Bruce Lee, who is at Johns Hopkins University, a longtime collaborator of mine, is the person that started this project and is the scientific director or the scientific lead of the project. And I also want to call out Kim Wong, who is at the University of Pittsburgh and with the SAM project is also the initial developer of the RHEA modeling system, and Joel Welling and James Leonard, who are in my group, are also developing the next generation of this model. So the next project I want to tell you about is a project called HERMES, which everybody wants to know what that stands for. It stands for Highly Extensive Resource for Modeling Event-Driven Supply Chains. That's why we call it HERMES instead of the full name. But HERMES is a project that we've been working on for quite some time, mostly with the Bill and Melinda Gates Foundation, but also with a number of international organizations such as the WHO, UNICEF, and a number of NGOs, looking at how do we get mostly health products down to people that need them. So supply chains are a critical component of this, especially in lower and middle income countries where there's not a lot of infrastructure. And so we've developed a simulation model that takes a number of different data items, such as the structure of the supply chain, storage locations, transport personnel, and it feeds into HERMES and creates a very dynamic simulation model. And in many cases, a lot of people use sort of like static spreadsheet models to do this work. work. This is a fully dynamic model. It's sort of like a sim city for vaccine supply or health product supply chains, which again allows us to have a virtual laboratory to guide data collection, identify and evaluate options, and test strategies. This movie here is a sort of a picture of our Hermes model and the supply chain of Niger, which is in Africa. Each of these columns represent a location on the supply chain, and this is the immunization supply chain. So one of the things about vaccines is that they have to stay cold. There has to be a cold chain in order for them to remain potent and not spoil. And so in many of these countries, this is very challenging because keeping reliable electricity, making sure that trucks are available, people and personnel are available when people need vaccines is challenging. And so that's one of the reasons that we built this model. So every one of these columns is a location on the supply chain, which there's something like 800 and some in this country. As the columns rise, that's actually product or vaccines arriving at this location, and as they get taller and the columns go red, that's indicating that they are the available storage in these facilities are filling up. So that's one of the things that occurs is that if they haven't updated the storage, or if things start breaking, or they just don't have enough storage, they'll end up having to waste vaccines because they'll have to throw them away because they can't put them in the refrigerator. And then there's different levels of the supply chain. The bigger the column, the level of the supply indicates the level of the supply chain. So vaccines come in to the really big column there, which is in Niamey, which is the capital of the country, and then move down through the different levels until they get down to the really little columns, which are integrated health centers where people actually come to get vaccines. And you can see those columns going down lower, kind of gradually. That's people actually coming to the clinic to get vaccines in the model, and that's depleting the supply of vaccines. You'll see some lines forming between some of the places. That's actually transport occurring. So we actually model all of the transport from motorbikes to trucks to cold trucks to, I think, Leila, we have some cows in one of the model. We have horses, buses, people that walk. We can model pretty much any chain. But what you'll immediately notice is there's huge areas in this country where nothing's happening. And that's because there are bottlenecks in the supply chain, and that it's causing vaccines not to get there. So that is populations that don't get vaccinated. Those are children that could get vaccinated against preventable diseases that may get sick or die because they can't get the vaccines there. And so one of the reasons we built Hermes is to help countries like Niger be able to model their supply chains, change it around, and figure out how to fix this problem and get vaccines to everyone in the country. So some example topics that Hermes can address, along with some sample publications. Introducing new vaccines and technologies, so things like adding, this decade was labeled the decade of vaccines, so there were a lot of development of new vaccines such as rotavirus, pneumococcal vaccines, and they're being introduced in the countries, but the countries may not be ready for them or need help figuring out how to get ready for them because those add lots of storage requirements and transport requirements to their supply chains, and if they haven't been updated, they may not be ready for those. Altering characteristics of the vaccines and other technologies, things like making vaccines thermostable, for instance, is one of the things we've looked at. Looking at different presentations of vaccines. Is it more effective to have larger doses per vial? So vaccines come in vials that have 10 to 20 doses in them in some cases, which also can lead to contamination and make using them a little bit more difficult. But looking at how those technologies impact the supply chain. Changing the configuration and operations of the supply chain. So we've gone to many countries and looked at and tried to advise them on how they can rearrange their supply chain to make it more efficient. They may not have the most efficient structure for their supply chain. If we want to invest and allocate new resources, such as buy new fridges, buy new transport devices, where will that investment be most impactful? Hermes can help you answer that. And then optimizing vaccine delivery and also making sure that we have equitable vaccine delivery, make sure the entire country or the entire area or region that we're looking at will actually get vaccines when they need them. So just a timeline of the different projects that we worked in. This is we've gone to many countries and helped a lot of governments and organizations with on matters of supply chain, of immunization and other health product supply chains with Hermes. We started the team in 2009 as a collaboration between our group at the PSC and Johns Hopkins University, and then we've had engagements in Niger, Thailand, Vietnam, Senegal. We've looked at things like passive storage devices. You may have heard Bill Gates talk about the magic thermos, as he calls it, which is a device that doesn't need electricity, it just needs ice and can keep vaccines for up to like 4 weeks without being recharged. So we've done modeling around that. We've done large engagements with organizations such as the Clinton Health Access Initiative, or CHI, Gavi, the Gates Foundation, UNICEF, looking at how can we generalize the idea of vaccine supply chain redesign? What are some common things that we can do to vaccine supply chains in countries that will help get the vaccines down to needed populations? We had a very intense engagement in Benin where we actually went to the country and worked with their government, intimately with their government, to develop scenarios. We built a supply chain, a full supply chain model of their entire country, including every location, every person in the country that would need vaccines, all the transport. And then we worked with the government to decide what kind of things would they like to see change in their supply chain to help prepare them for the new vaccines coming in and improve performance and efficiency. And so we then came back to Pittsburgh and built a number of different scenarios, ran a lot of models, compiled the results, and then went back to Benin and presented this in front of the Ministry of Health. And at the meeting, they actually said, "That sounds great. Let's do that," which was the intervention that we suggested, which was a consolidation of one of the supply chain levels as well as introducing transport loops. Well, the story continues after our engagement in that a group, AMP, who we worked with, and they were leading this thing called Logivac in the country. They actually piloted this intervention in one of the communes in Benin and found that UNICEF did an evaluation and found that it was vastly improving efficiency and getting vaccines to people that needed them in a much more timely fashion. And so they've decided to scale up that intervention to the entire country. So it's an example of modeling actually moving towards actual real-world policy, and that Benin is actually taking what we told them in our model and implementing it now on the ground to improve getting vaccines to their kids and needed populations. We also have worked in India, where we modeled 3 states, Gujarat, Bihar, and Kerala, with the Gates Foundation and a group called PHFI and Oakland. We've also worked in Kenya. We worked with the Decade of Vaccines Initiative to look at a wide range of supply chain economics estimations for a number of different countries to provide sort of a global picture of what is needed for vaccine improvement. We've also worked in Mozambique, and we've done some work with unmanned aerial vehicles, which Leila will be telling you about in a little bit. And recently we've also worked with USAID and performed a evaluation of their HIV, malaria, and family planning global supply chain. So that's a very large supply chain that we've also used Hermes to do. So we've worked in a lot of different countries. We've actually gone to these countries and done workshops, hands-on workshops with our tool, and tried to help people. The vision of Hermes is to not just for us to do the modeling, but to provide a tool for the international community to be able to pick up and use themselves to improve their supply chain. This is a very densely packed slide to show you. We've published a lot of work. These are all the publications that we've had for Hermes, so there's plenty in the literature for if anybody's interested in learning about Hermes. And as I was saying, we are trying to make this a usable tool, so we've developed a graphical user interface to the tool that allows decision makers and people in country to actually pick up and create their own supply chain models, run them, try scenarios, see what the results are, and so that it transforms from a consultation with us to them actually being able to have this capability themselves. Here's the logistics modeling, the Hermes logistics modeling team. Just a couple people to call out. Jen Bacall is also, and Jay DePasse are also in my group. We're in the previous slide. We have a number of people from Johns Hopkins University, including Marie Ferguson, Daniel Herdenstein, Patrick Wedlock, and Marie Spiker, who are great and help out with and do a lot of the modeling. Our coordinator, of course, we couldn't do it without, Leila Haidari, who we hear from in a little bit with a Hermes project. And Joel Welling is actually the primary author of the software that we're using and is a longtime researcher here at the PSC. So the final application that I want to tell you about is a new one, probably the newest one that we've gone into. We are part of an organization called the Global Obesity Prevention Center, which is centered at Johns Hopkins Bloomberg School of Public Health. Bruce Lee, who, as I mentioned before, is a longtime collaborator of mine, is the executive director of the center, and it involves a number of different institutes at Johns Hopkins University and also the Pittsburgh Supercomputing Center here at Carnegie Mellon. So obesity, global obesity is a huge problem. No pun intended. It's a growing concern, not just in countries like the United States, but all over the world as people are getting more industrialized, as food is becoming different around the world. It's a growing, people will call it an epidemic of obesity. And so what we have sought to do is, similarly to our other modeling efforts, we've taken a systems approach where we have all these factors that are associated with global obesity, and we're trying to make models that allow us to create virtual laboratories to understand how, what factors affect obesity and how can we prevent it and how can we create interventions both on the dietary and physical activity level to help people, help populations battle against this epidemic of obesity. So what we're doing is we're creating another agent-based model, which we're calling VPOP, which stands for Virtual Population for Obesity Prevention. It's, again, like all the other models, it's kind of like a Sim City. It's a virtual population with a virtual society where we're going to then be able to track the behavior of all of the people in the population and what factors will affect their growth, including food intake, exercise, and the like, and be able to then have a laboratory be able to test interventions, give policymakers the ability to say, you know, if I try this, am I going to have the effect, where am I going to get the biggest bang for my buck? Obesity is a very complicated problem. There's lots of factors, including biology, social factors, the dietary factors, a lot of factors that are associated with obesity. So this is a really interesting approach to this, to trying to explore the problem of obesity and allow us to be able to take our model to any population in the world and be able to model interventions and that affect the growth of the children in the population. So VPOP has a representation of all of important locations. These are actually more than influenza models. Obviously, there are things like households, workplaces, and schools for kids and adults, but also we're modeling things like food sources and modeling physical activity locations such as parks, gyms. We're also modeling road networks so that we can track how long it may take for people to walk and get physical activity during their day, to be able to understand how all of these factors affect children's growth or people's growth and their obesity status. And again, each person is represented by a computational agent. They have a number of different factors that can be used to track them through the population and look at how different external impacts affect, and their own personal decisions affect their obesity status. And we've started this in Baltimore, but we are also looking at all sorts of other populations. We're utilizing the synthetic population technology that we've been using for influenza to be able to model a number of different locations as well. So this will be a very flexible model that allows you to go to any region in the United States or the world and understand how can we prevent or intervene in obesity. One of the unique things about this is that each agent in our model actually is embedded with a metabolic model. So you may be wondering, how do we track how people might grow over time? Well, we actually have every agent has a model that was developed by Kevin Hall, who is a very well-known researcher at the NIH that has developed these models of energy balance that actually can help us understand, as our agents eat, how much calories they take in, how much energy they take in, and how much energy they expend doing physical activity. What will that impact be on their growth over time? So we can actually look at how their fat mass and fat-free mass evolves over time based on the amount of energy that they consume and the amount of energy they expend during their activities in the model.
What's the interaction between the agents here?
What's the interaction between? Well, it's complex. So I'll leave this one up while I'm answering that. So it's complex. It depends on. So kids will go to school and interact with other kids. We are currently working on things like modeling peer networks so that it affects their decisions.
Kids interact with other kids means what? They look at what they eat for lunch and they may ask for that kind of lunch.
Or they may have, their friends and peers may have preferences towards food that may affect their decision on what they eat. Their parents may have an influence on that. Their parents will certainly have an influence on what they eat at home. It will also affect when they eat. They may snack more or less, depending on their peer network. It really sort of depends on the question we're looking at, but there's lots of interactions between the agents that were, and it's also interactions with the external environment. So the food sources available to them within their periphery, and that will dictate what they can eat and what they choose to eat, and what's available at their school. They have vending machines that have healthy options versus Coke in there, things like that. So it's there's lots of different interactions that can lead to this. And so, again, this is just an animation of our model, excuse me, where you have every one of the agents. These little dots here are the agents, and they're moving around through their day, and we're tracking what they do, where they eat, what they eat, and that all, again, emerges up into a population level of obesity, and we can then track how we can actually mitigate that. And this is the system science core of the Global Obesity Prevention Center. Actually, I should say that I'm also the director of computational research for the Global Obesity Prevention Center. We have a number of different collaborators working on this project. Molly Domino, Cindiso, Niathi, and Maria Solano Gonzalez are people at the Johns Hopkins Global Obesity Prevention Center that really help us out a lot and do some, these two do programming, and Cindiso is very great at doing research. I should have changed that from BS to PhD. The recently anointed Michelle Wong has developed, Dr. Michelle Wong has developed models for physical activity and its interaction with crime. And I should mention the lead developer, Daniel Hertzstein, who sort of manages the development of this project, is also a key person in this project. And I forgot to update this with MD PhD. Adam actually just got his PhD as well, and he's been developing economic models that we can use to estimate the economic burden of obesity on populations. So just some acknowledgments of all the projects I talked about. We have a number of different funding sources. As you can see, most of them are from the NIH. There's a number of different grants that we have that are funding this work, as well as funding from the Bill and Melinda Gates Foundation and from UNICEF. So I'll stop and I'll open the floor for questions on my talk, and then we'll move on to the next talk. Are there any questions that haven't been asked already? Excuse me. Okay, great. Well, thank you.
The obesity thing. Mm-hmm. I mean, how many agents are in there?
Depends on the population that you're looking at. In Baltimore, there are something like, how many agents are there in Baltimore, Eli, like the children agents in the Baltimore model? Rough estimate. Tens of thousands?
20 to 30,000.
Yeah, it depends on the city we're looking at and the age group that we're doing the study. But it can range from tens of thousands to millions, depending on the area that we're looking at.
And how long does a run take? And
again, that depends on, the model varies depending on what's turned on. It can take a couple hours to run one simulation. It could take a day. Depends on what we have. All of our models, essentially, except for our influenza model, are written in Python, and we've actually found that to be a very flexible platform, and we've been able to get decent performance out of it. So we're really happy with using. We're pretty much a Python shop, and so VPOP is being developed completely in Python. Okay. Any other questions? Yeah.
One time I drove through West Virginia, I found the local had much higher obesity rate. Mm-hmm. Any explanation for that?
No. Not yet. I mean, there's probably a number of different factors. I don't want to comment on what they might be because we haven't done any modeling there. But I mean, there's lots of factors that contribute to obesity: a lack of physical activity, people being sedentary, diets being poor, not having access to good, wholesome and fresh food, fresh vegetables. And so there's a number of different factors that could be involved there. It's a complex problem. Hence why we're building a very complex model to look at it. Okay, any other questions? Great, well thank you very much, and I would like to now take the opportunity to introduce Ms. Leila Haidari, who is the Public Health Applications Manager here at the Pittsburgh Supercomputing Center. I have been working with Leila, you can come up. Been working with Leila for, what is it now, about 7 years?
5 years.
5 years. Sorry, I'm old, I lose track. Same difference. Leila is the coordinator of our Hermes project as well, and she's been critical to the success of Hermes and done most of those papers that you see on the publication list. Leila has contributed to in multiple and various ways, so we're very lucky to have her, and she'll be speaking today on her work with unmanned drones and delivering vaccines. So you can use that, or you can use layers.
Okay, thanks. So yeah, I'm going to talk about a study we did using the Hermes tool that Shawn briefly talked about earlier to look at the value of using drones to transport vaccines as opposed to traditional land vehicles. So this is a piece that our Hermes team scientific lead Bruce Lee wrote for Forbes, and the answer is basically no, vaccines don't often get to where they need to be. In countries all around the world, kids show up to health facilities to get vaccines that may potentially be life-saving, and they may not be there due to supply chain issues. So we used our Hermes modeling tool to make a simulation model of a vaccine supply chain in the Gaza province in Mozambique. And we looked at, I can go ahead and move on to this one. So for this study, we looked at one province in Mozambique, but we did a range of sensitivity analyses to look at what conditions would make it optimal to use drones to deliver vaccines instead of trucks or motorbikes, and what the potential cost savings might be. So we compared the traditional land transport system that's been used for decades in Mozambique. They typically have it is very common to other countries that we modeled as well. They'll have, like, in the one province that we looked at, they have one depot or warehouse in the capital of the province, and from there the vaccines are transported by truck to different district stores throughout the province, and then from there they travel either by truck or motorbike or even public transportation to get to the clinics where they're administered to the children and pregnant women who need them. And we looked at a potential implementation of a UAV system that would still use trucks for part of the supply chain. So you'd use the trucks to deliver them to a depot, but then from that depot you would use unmanned aerial vehicles or drones to transport the vaccines to the health facilities. And in the particular system we modeled, they could transport up to 1.5 liters of vaccines in their packaging at a time, and they could go up to 75 kilometers away from the hub before having to go back. So these are visualizations of these two different systems. Initially we looked at how we could potentially use drones in as much of the province as possible. So on the left-hand side is the traditional system, so this is only using trucks and motorbikes and public transport. The provincial store or warehouse is right here, or no, you can't see my cursor. This is the provincial warehouse down here by the coast, and these other yellow circles represent the district stores, and then the smaller white circles are the health facilities where the vaccines ultimately need to get. On the right-hand side is a potential implementation of the drone system. We quickly realized that it wouldn't make sense to put the drones in the northern part of the province because the population is very sparse and spread out, so you would need a lot of these hubs, and they wouldn't be able to serve many clinics at all. And the hubs, I should mention, have a very large upfront infrastructure cost that we could talk about more when we get into the results. But so in this potential implementation, we would still have the provincial warehouse, and from there we placed 3 different hubs that could cover as many of the 123 health centers in the province as possible. So those are shown in blue, the health centers that are served by drones. And in this system, we would use 3 different hubs, and in the northern area, we would just still use trucks and motorbikes to distribute the vaccines. So for this potential implementation, we did see an increase in vaccine availability and a reduction in the logistics cost per dose administered. These are the two main metrics we use to compare the systems. Vaccine availability basically means the percentage of doses of vaccine that are needed that were actually where they needed to be when they needed to be when the children came to get them. So we saw that you could potentially have high vaccine availability with the traditional system, but it could actually increase to 96% with this drone system due to fewer transport delays and other bottlenecks related to the traditional land transport system. The logistics cost per dose administered is basically the total logistics costs, so that's storage, transport, labor, and the buildings, and we divide that by the total number of doses administered. So that gives some idea of the efficiency. So that actually dropped, and that was because of lower costs overall, but as well as more doses being administered. Now we did another comparison where we looked at a smaller part of the province so that we could have a more direct comparison between using just land transport or just UAVs. So for this system, we just looked at the health centers that were within a 75-kilometer radius of the provincial warehouse. And so we placed a UAV hub there, and we only included the health centers that were in that radius for both systems. So here's what the traditional land transport system would look like, delivering to just those health centers, as well as the UAV system on the right. And so that still showed an increase in vaccine availability and a reduction in the logistics cost per dose administered. It was still about 8 to 9 cents per dose savings. But the reason we wanted to look at this smaller model was because it allowed us to make some more comparisons. We were able to vary different parameters in that model to see how well the UAV system might perform in different settings. So if you're outside of Mozambique, or if the population was different, or after you introduced vaccines, would the UAV system still provide savings, and how might that be impacted by varying these parameters? So this is a tornado diagram. The parameters that had the biggest impact on the savings are shown at the top. As you'll see throughout, the savings remained positive. They were greater than 0 for all of these sensitivity analyses, which means the UAV system still achieved cost savings over the land transport system in every scenario we looked at here. The road speed had the biggest impact. Road distance was also a major factor. So I guess that shows that if you're looking to implement UAV systems, the road conditions would be a major factor in whether the UAV system might be successful. The throughput or population also had a large impact. We saw as we had larger populations at each health center, the savings were less, whereas when we had smaller populations, but at a lot of different health centers, the savings were greater. We also looked at differences in population distribution, as well as having impassable roads during parts of the year, and vehicle lifetimes and vaccine introductions. Another concern around using UAVs for vaccine transport is the flight condition requirements for the UAVs. There were concerns that when weather is bad, you wouldn't be able to fly the UAVs, and that could actually lead to delays that may not make it much better than the road vehicles that also face delays. So in these, we kind of gradually increased the duration of the delays. And for these simulations, each trip had each flight had a 50% chance of having a delay of either 1 week, 2 weeks, 3 weeks, or 4 weeks in these different scenarios. And these, the lines show the thresholds at which the UAV system would stop being cost saving. So if the hub cost was greater than the blue line shows, or if the UAV cost per trip is greater than the red line shows, then the system would stop being cost saving. And I guess, so what we found with this was that short delays did not have a dramatic effect. Realistically, they don't think that UAVs would be delayed by more than a day or two. So, so these results show that, you would actually have to have pretty dramatic delays of more than 2 weeks in order for the system to potentially stop being cost saving as compared to the land transport systems. And it's also worth noting that the system that we modeled, their current costs appear to be lower than these thresholds, even up to 2 weeks. We also found the payload capacity that would be required for the UAV system to achieve cost savings. So we did analyses for the current vaccine schedule as well as after introducing vaccines. And we also looked at if the UAV hub and vehicle costs did not actually achieve the at-scale costs, but if they remained at the current costs that we were quoted. And in all these situations, the payload could still be very small and still achieve cost savings because it looked like the maximum requirement would be 0.4 liters, and the current capacity of the system we modeled had a 1.5 liter capacity. So some limitations of this study include the fact that we didn't necessarily vary every factor that could possibly impact whether the UAVs achieve cost savings. We only compared to one traditional land transport system, whereas there may be others that would look better compared to the UAVs. We also made certain assumptions around how well the UAV system might be accepted, whereas in reality there may be challenges around compliance with policies, and as well as how much people might accept the idea of having drones flying their vaccines around. But field testing could provide additional data. So in summary, the simulation modeling found that in general, UAVs may be able to provide equivalent or slightly better demand fulfillment compared to this traditional land transport system in a variety of scenarios. Simulation modeling can help with developing such technology and assessing it before piloting it in the field. And major drivings of these cost savings provided by the UAVs were major drivers were road speed of traditional land vehicles, the people needing to be vaccinated, and road distances. And the UAVs could still provide savings even if weather conditions cause 50% of flights to be delayed by a week. So I'd like to acknowledge our collaborators and co-authors of Village Reach, and this study was supported by the Bill and Melinda Gates Foundation. And this is our team. I believe most of them have already been introduced by Shawn, so if there are any questions.
What's the probability of success of each UAV attempt?
In the model, unless we had modeled delays, then we assumed that each flight was successful.
In reality, is that a 99% thing or?
I guess when we were collecting data for this, they didn't really indicate any percentage of failure. They were in the early pilot tests, but I know that this company that we did work with is currently using their drones to transport blood samples in Rwanda. So I don't know if, I haven't seen any numbers about, from their field work so far.
Leila, coming back to your tornado diagram, what was the difference between the green and the blue?
Oh, right. The green and the colors represented whether that parameter was very higher or lower. So like if road speed was very low, then the UAVs would provide a greater cost savings because the land transport would do worse by comparison.
Thank you.
What was the speed of the UAVs? Road conditions above or below that? Is that what triggered it? Or?
Yeah, that's a good. I think I have. I have the mean for the land vehicles. It was 59 kilometers an hour. I believe the UAVs were faster than that at baseline.
Well, and on top of that, they don't have to use the road.
Right.
They're going straight. Well, I was wondering how fast they were.
So on your first diagram where you had the on the subset of the region, that one where it's all UAV, how many UAVs are there? Is it a UAV for each of the blue delivery dots, or is there some smaller amount that comes back, gets more, and then distributes it again?
Yeah, I don't remember exactly how many we placed at the hub, but you wouldn't necessarily need one UAV for every route because you could, send the same UAV to multiple places in a day.
And you mentioned the cost, that there was some kind of a one-time cost for setting it up.
Yeah.
Is this recurring, or is it a one-time thing?
The hub placed at the provincial store would have a large infrastructure cost. So a lot of that is just the upfront cost of building it, but then over time the maintenance costs would also be higher than for the traditional infrastructure for land vehicles.
You get your 22 cents versus 31 cents. your savings, that includes those one-time costs.
Yeah, we amortize
Well,
that.
should actually go down even more if those costs aren't recurring, right?
Yeah, well, we amortize the upfront
Okay.
capital investment
So you
over,
do
so yeah.
Over how long?
I believe, I can't remember what the lifetime of those hubs was, but I think it was around 10 years.
Oh, okay.
So the lifetime of the device. And in the case of the UAVs, it's, their capital expenditure is amortized over the lifetime in kilometers that they would do. So as they travel, the more kilometers they travel, the more of the amortized costs they incur in their recurring costs.
Thanks.
Any other questions?
Are the UAVs piloted or autonomous?
They're autonomous. Okay. You can bring this to Jay's slides.
Great. Well, let's all thank you. And I'd like to introduce our final presenter today, Jay DePasse, who has pretty much been with us since the inception of the group. And before that, we worked together when you were at the University of Pittsburgh, working on agent-based models. Jay is our software manager here in the public health applications team, and very talented man, very good programmer, very good technician, but also a great modeler. He's going to tell us about some of the work that he's been doing in influenza modeling and vaccines. So,
thank you, Shawn. Okay, so I know I'm the last talk, so I will keep it moving. But I'm going to talk about some work that we did with collaborators at the University of Pittsburgh and at the University of Seoul in South Korea. And this is the publication, which is now available online. I don't know when it actually comes out in print. But we're looking at how to reduce disease burden by offering people a choice of the different types of vaccines that they can receive. And this is a cost-effectiveness analysis on top of an agent-based model. The agent-based model is FRED. This is one that, the agent-based model that Shawn described earlier, and a similar cost-effectiveness analysis that he outlined. So you may ask, how is the premise? Does it make sense that offering choice of vaccine type, will that actually increase people's propensity to accept the vaccine? And we based this on a clinical study that says that, in fact, there is an increase in the coverage of vaccine whenever you offer a choice of a traditional vaccine and a needle-sparing vaccine. And there are two different types of needle-sparing vaccines that we looked at. One is the LAIV, where it's inhaled through the nose, and then an intradermal vaccine, which is still a needle, but a much smaller needle in the skin, as opposed to the traditional intramuscular, which is more painful. So I personally think, there's a little human psychology there. If you have a bad alternative and a slightly better alternative, puts a shine on the better alternative. But that was the assumption that we made. And we're looking at the cost and the effect. The increased coverage can reduce disease burden through direct, that is, the vaccine prevents illness in an individual, and indirect, by protecting yourself, you protect the people around you. And we take into account the fact that offering a choice isn't free. We have a more complex array of vaccines that have to be stocked. There are costs for the physicians or pharmacists to consult people and tell them the different attributes of the vaccines, and then you have storage, handling, and wastage. So we make assumptions about how much that will cost on top of the base cost of the vaccine. So under what assumptions about this increase is it going to be cost effective? When does it make sense to implement this policy? When are we going to have a positive health outcome at a reasonable cost? So our methods, we used an agent-based model in a synthetic population of the Washington, D.C. area of about 8 million people. And the baseline age-specific vaccine coverage for the different vaccine types. And there are some letters there. So IIV is inactivated influenza vaccine, IM, intramuscular, and then inactivated influenza vaccine, intradermal. The LAIV, this is the one that you inhale, and then high dose is not a needle-sparing vaccine, but this is given for older people. It is still an intramuscular inactivated vaccine, just in higher doses. And we matched these to historical vaccination rates from the period of 2009 to 2014, and calibrated that to provide our baseline. So the costs were calculated by taking the number of symptomatic cases reported by the ABM for vaccinated and unvaccinated individuals, and we fed these into a probabilistic decision analysis model, which is a Markov model on a 1 month time step. And at each time step, we take the number of cases of people that are vaccinated and unvaccinated and run this many times with assumptions about the healthcare costs. And we can, this way, compute the total cost to society for each different epidemic scenario that we looked at. And by the decision analysis model is very inexpensive to run. This is something that runs on a desktop. We use the triage software. But it allows us to easily vary the cost assumptions over wide ranges in sensitivity analysis. And we can also vary some of the assumptions that come out of the ABM, but the primary information comes out of the ABM. It's a lot more expensive to run than the DA model. So the different experimental scenarios that we looked at. So we offered vaccine choice to targeted age groups. We looked at, starting from the baseline, offering a choice of this needle-sparing vaccine to children, ages 2 to 18, or to adults, or to both. And the idea is it enough to stop here, to simply offer choice to children, or adults alternatively, or to both? And to account for uncertainty in the assumptions of the model, we varied R0 across a range of 1 to 1.6. As Shawn mentioned earlier, this is the commonly accepted value of R0 for influenza, and varied the assumptions about the increase in coverage due to choice from 3.25 to 11.25. The nominal value in the middle of that was that reported in the clinical study. And then the additional cost of choice, this was arrived at by our clinician collaborators at the University of Pittsburgh, was an additional 2.5 to 7.5% of the normal cost of the vaccine.
In addition to increase in coverage, there's sort of somehow, there's another measure, right, which is the increase or decrease in the number of people infected and something. You have information on that?
Well, that's an outcome of the model, right? So we vary R0.
Yeah, okay.
And then we run the agent-based model, a number of stochastic realizations for each of these sets of parameters, and then the agent-based model produces a number of symptomatic cases.
Oh, so this second bullet, that's different runs you've done.
Correct.
Okay,
right.
Sorry.
Yeah, it ended up being a factorial experiment design.
Do all types have the same effective rate?
In this study, we did make that assumption. We did provide the means to vary it because it does vary. And actually, we did some preliminary work and found that there was not. It did not impact the conclusions of this study. But to directly answer your question, yeah, different vaccines for different age groups will have differing efficacies from year to year.
I'm sorry, I don't understand that what you mean by choice here. This is a choice of the different vaccine, or is it the same vaccine and a choice of how it's dosed? Whether by inhaling or needle or both?
So in this case, it is simply the route of administration that changes.
Okay.
Yeah.
It's the same vaccine?
Yes. Though
Because there was the higher dose, there was the muscular one, and I thought those were all the same vaccine.
The higher dose vaccine was not included as it's not a needle-sparing vaccine. The experience of receiving the high-dose vaccine is every bit as unpleasant as receiving the traditional vaccine. So it would not have this effect of increasing vaccine coverage. But of those, the only thing that we looked at, we did not assume that because having differing efficacies would complicate matters. We didn't look at that. So you can assume that the vaccine was the same. It's just the route of administration, and the act of offering choice increases the coverage. So we did almost 4,000 individual simulations run on the Olympus cluster, and because of the size of this experiment and the data management challenges that come along with it, we have some custom Python code that we can specify these sensitivity parameters and the different scenarios in an input file, and then the product of those different parameters blown up and commissioned using Python code that I can run interactively. And it collects the data back for analysis that was performed using an R Markdown document. This lets us put the analysis in line with a description of the analysis and the figures that it produces, so that the first version of our paper comes right out of the machine. So this, in a complex analysis like this, it reduces the chance of simple human error. Everything, if we have a question about it, I can press a button and run it again. So, on to the results. We have an epidemic curve, which we saw some more complicated epidemic curves earlier. This one is it's averaged over the different stochastic realizations, and then a week-long rolling average to smooth it out. But you can see up the top, I'm not tall enough. The baseline is in purple, and we have a reduction from that baseline, a reduction and a slight delay in time. We have the epidemic day. This is the time progression of the epidemic and the number of cases on the y-axis. To the pediatric choice, whenever we offer choice only to children, and then you can see that the adult choice, interestingly, it reduces the number of symptomatic cases more so than does the pediatric choice, and the greatest reduction comes from offering choice to both. Which makes sense, because we're increasing the number of vaccines to go out into the population. But something that you can see perhaps more clearly on this slide and the next is that even in the adult choice setting, you have these now we're seeing averted cases, so these are all relative to that baseline. You see a greater number of averted cases in green for the adult choice than you do for the pediatric choice, even in the children, the age and years here. So this dashed gray line shows the dividing line between children and adults. So this is the indirect effect. By vaccinating adults, then the children don't get sick and the children don't spread it, and you have the relationship is not simply the age group that is vaccinated. You have the indirect effects. And this is another similar set of plots. This time, it only varies by how they are grouped. We're still looking at additional averted cases, and here we're looking at the effect for the increase in coverage. This is the assumption that we made going from 3% to 11% for how much additional coverage you'll get by offering choice. And the effect is greatest whenever we assume, we make the most optimistic assumption about the increase in coverage due to choice. But even with the lower end of the assumption, we still get the additional averted cases. So conclusions, we significantly decreased the disease burden by offering choice. And despite this higher cost that comes along with offering a choice of alternative vaccines, all of the choice scenarios were cost-effective under sensitivity analyses. The greatest effect was observed in the adult age group, but the choice for both age groups was dominant, and in that it gave the greatest gain in health for the cost under all the parameter values. So even though you had an incremental gain going from adult offering choice only to adults to offering choice to adults and children, it's still cost effective. You still get more back than what you put in. And with that, I'll acknowledge the Pitt Vax team, led by Rick Zimmerman at Pitt, and the 2 grants, the R01 that funded this directly, and the Olympus compute cluster that is provided by the Midas ISG. So, yes.
Question. Not about this in particular, but about agent-based modeling. I mean, what is known, if anything, about scalability rules or something like this? You know, I mean, could I, at the expense of some estimatable increase in sensitivity, do half the number or something like that?
Half the number of stochastic realizations.
People, somebody did 8 million people for the Washington area. I mean, suppose I do. I mean, the structure of an area for some of these things is an important factor. So I don't know that you can generalize in that. But I mean, you know, what if you did? And as far as I can tell, the computational costs here aren't anywhere near prohibitive. But you know, can you draw? I mean, is there anything known about just agent-based modeling for scaling laws?
So the synthetic populations are detailed and realistic, and it wasn't described here, but we took this same framework and then, based on a reviewer question after we submitted this paper, what is the effect of running this experiment in different geographic locations? So we ran it in 5 different locations that differed by age structure, and we got different results, right? So that is
right. Those are
it's not strictly the number of people that you're asking. It's
I would ask a different question, and that is, you did this for 8 million people. What if I made a 4 million people sample by randomly selecting from the 8 million people and run that?
You would have to maintain a number of marginals that would be difficult to, right? I mean, these people come from households. These people go to schools. So you're going to sample, you're going to reduce the number of people in a school, you're going to reduce the number of people in a household. Do you sample by household or by school, or if you get what I'm saying there? It would not be a simple matter of just reducing the total number.
What you're suggesting would be analogous to doing essentially a cohort study. So you would have to, I mean, if you randomly sampling, it depends on how many, I mean, if you sample 4 million people out of 7 million, you probably get as much demographic as you need. But, you know, when you're doing
I wouldn't think you can go very low, and there's probably no point in going higher. But I mean, it's really a mathematics question as to what exists. I mean, because the 4 million out of 8 million is already a pretty good number, right?
Well, I mean, like in polling, like for surveys and things, or, you know, opinion polls, there are known statistics
They're just
as
doing,
to how much
they're
you,
just
how much
doing,
you have.
yeah,
to
they're
send
just,
them.
that's bullshit, that's just the
No,
number.
but they work
Usually
out.
that may be, but all they put in for errors
Like
is
you
the
can
square
ask
root,
2,000.
square root of the number of,
Right, right.
This is more complicated.
It is, but is that what I'm saying is maybe, is there an equivalent understanding of, in a given the number of people in that population, how many agents do I need to have a representative result?
There are papers that explore that. Nobody gives you it depends on the question you're trying to ask, is really what it amounts to.
Representative of flock behavior.
This is not like a standard physics technique. I mean, these are, the models are kind of different depending on what question or what problem you're looking at. And so, the question you're asking will vary depending on the question that what the model's trying to represent.
Yeah, maybe the only thing that's concrete would be below a certain size, you'll get stochastic die-off of the epidemic, right?
No, I.
We also spend a lot of time just tuning the model rather than saying, this is what it looks like in real life. How can we figure out how can we match it? If we wanted to size our population smaller, we probably could, but then we'd have to do a tuning step and look very different.
Okay. Shawn, do you want to say any additional words? If not,
Any other more questions?
I have a question. So why pose this question is, or I guess, what percent of people would prefer a shot over a mist? Is it high enough that you, and what's the cost of the two implementation methods? So if the cost wasn't that high, they just give mist and it was just as effective. If you just said, that's the only stock we're going to carry, would everyone choose that? Or would some people say, no, I'm not going to, I can't do a mist, I need a shot?
So the needle-sparing vaccines are not recommended for all age. So this is one issue. You
Why
need.
Are they not recommended?
They're not. They're the.
They're just not. They're efficacy, safety.
Yeah. So you need to have this portfolio
Really
of vaccines.
I mean, right? I mean, they have different effects. These things.
They're produced in different ways, so they're not necessarily they're influenza vaccines, but they're not necessarily the same vaccine.
Yeah, even though they are inactivated, they may have been cultured in the eggs versus canine liver cells or something. No, I think that's actually how they do it.
I guess my concern would be is if they're not effective for a certain populace, then giving it to them doesn't give the same effective rate for your model. If you assume they're the exact same effective rate, your model's going to mislead you.
Yeah. The other thing is this paper does say that if you only offered the needle-sparing vaccine, you would get coverage X. And if you only offered the needle vaccine, you'd get coverage Y. If you offer them both, you get a coverage that is higher than either.
Right.
By simply offering the choice. So.
But isn't that because more people are accepting to take one of the two?
Mm-hmm. Right.
It is.
That's your input. Is not any property of the vaccine. You made an assumption. That was that range,
Right.
the 3.85%. They made an assumption of how many people are going to show up, and that's the input to the
But
vote.
what I'm saying is if the percent more people that show up, if those people show up and say, well, I'm more willing to take this one because I'm not afraid of it, but it's not as effective for that populace.
It's still better.
In this case, yeah, that's true, and we did see that wasn't published or presented here. That even if you assume that the efficacy differs, it was still cost effective. But in this case, we assumed that the efficacy was the same for all vaccine types.
Also, people are not rational actors. They will, if given a choice, they are happier in many cases, even if the choice is between one thing that they definitely don't want and one thing that they're more happy with. They're happier with having that choice than being forced to have the
Right,
their
but
health.
if my doctor gives me a choice of a needle and just says it's effective, but he gives me a choice of a needle and it's 90% sure I'm not gonna get that disease, or he says you can take the flu mist and I'm 50% likely not to get that disease, there might be a whole lot of people that say, give me the mist, and then your efficacy rate is.
But that's not
That's
in
not what we're
this.
talking about here.
So those different, I should also point out that those differences in efficacy are not known at the time that you get the vaccine. It's not known until
Turns out.
after the fact, right?
So your doctor's not saying that.
Your doctor's not going to say that because 1 year it may be that the mist is more effective than the inactivated vaccine, and you don't. No, and you don't know that until after it plays out.
Because of the cocktail of each vaccine when they put in the different viruses.
There's so much that goes into it, yeah.
Okay, great. Any other questions? Now let's thank Jay. And, so I'd like to close our public health symposium. Thank you to all of you that joined us online to watch. We'll be probably holding another symposium from a different area of research at the Pittsburgh Supercomputing Center sometime in the near future. So please watch the Facebook page and website to find out more details. Thank you very much for joining us. Really appreciate it.